We had many anecdotes reported in the literature regarding patients not responding very nicely to tyrosine kinase inhibitors because they had some sort of bariatric surgery in the past. So that's why we tried to look what is the proper effect of bariatric surgery on CML treatment outcomes, because as of now, it's largely unknown. So we looked at a cohort at MD Anderson over a period of 20 years, and we took all our CML patients and identified those who had some sort of bariatric surgery, either bypass, sleeve, gastric banding. And then we identified a second control cohort using a propensity score matching for so-called score and body mass index. And then we analyzed event-free, failure-free, and overall survival between both cohorts. And we finally conducted univariate and multivariate analysis to determine what are the outcomes that are associated with worse overall survival. So both groups, either the gastric bypass or gastric surgery cohort and the control cohort, were perfectly matched in terms of age, gender, so-called risk, Charlson comorbidity index. And I'm gonna come back on this point later. So the Charlson comorbidity index determines how frail the patients are. The cohorts were matched also for body mass index, frontline TKI therapies as well. And interestingly, what we found is that patients who had bariatric surgery needed more TKIs throughout their life and course of disease compared to control, a median of 2 compared to a median of 1. And they needed more TKIs because they had more intolerance mostly to those TKIs. Patients with bariatric surgery had a higher time to decrease their BCR-ABL transcript, which we call the BCR-ABL halving time, which is expressed in days. So 26 days compared to 12 days in the control. A lower proportion of patients with bariatric surgery, 68%, achieved a BCR-ABL less than 10% at 3 months compared to 91% in the control group. Also, patients with bariatric surgery had a longer time to achieve complete cytogenetic remission, 6 months compared to 3 months in the control group. Also, for major molecular response, patients with bariatric surgery needed more time to achieve this milestone, 12 months compared to 6 months. Now let's look a bit into survival. So event-free survival was defined as the time from the start of therapy to either progression, transformation, or death. And we can see that patients with bariatric surgery had worse event-free survival with a median of 84 months compared to 198 months and a 5-year event-free survival rate of 60% compared to 77%. When we looked at failure-free survival, which on top of this accounted for treatment discontinuation for intolerance or for resistance, we found that patients with bariatric surgery had a worse failure-free survival with a median of 12 months compared to 185 months and a 5-year overall survival of 32% compared to 63%. Also, for overall survival, patients with bariatric surgery had a 5-year overall survival of 74% compared to 90% in the control group. And then when we conducted the multivariate univariate analysis, we found that bariatric surgery was the only independent factor for worse event-free and failure-free survival. However, it did not show up as an independent prognostic factor for overall survival. Rather, the Charlson comorbidity index was the only independent prognostic factor for worse overall survival. And this is probably because patients with bariatric surgery have other comorbidities. And even in the literature, some reports reported that they also have a reduced overall survival compared to the general population. So in summary, patients with bariatric surgery have slower responses to TKIs. Bariatric surgery is also associated with higher rates of treatment failure and a worse overall survival. And therefore, there is an unmet need to design treatment strategies for those patients.